Welcome to the session 2 of the COVID-19 KEMCA UK World Symposium. This is about management of COVID-19 and lessons for future. I'm Abdullah Gujjar. I'm CPD lead of this organization, and I will be moderating this session. The chair of the session is Dr. Rana Rehman, and co-chair is Dr. Majid Mushtaq. The rules of this session remain the same. If you have any question, please leave it in chat box. Please do not forget to fill the feedback forms which would be circulated after the webinar, and then you will be generated a CPD certificate. Let's move on to our first talk, which is about uncommon presentations of COVID-19. My speaker is Dr. Waqar Gaba. He is consultant physician, internal medicine, and stroke lead at Sheikh Khalifa Medical City, Abu Dhabi. He is UK trained and has COVID experience on front doors in Emirates. Over to you, Dr. Gaba.
Thank you so much, Abdullah, for the kind introduction. Thank you, Chair KEMCA. Thank you, Chair Dr. Rana, Rehman, and the co-chair. And thank you for this, giving this honor. So without further ado, I think probably I'll share my screen. That's just a disclosure. Now, moving on to the objectives of my first talk. We'll first talk about just one slide for the common symptoms of COVID-19. This is not actually my talk today, but we'll just talk about in one slide. We'll then swiftly move on to the extrapulmonary presentations of COVID-19. As we now all know, the common complications and the common presentations are chest symptoms. We'll then talk about actually the COVID, how it's involving multi-systems and multi-organs, and I'll also share our local experience. So this is just a slide to explain that we all know that how common is coronavirus is, and then you can see the symptoms leading to fever, cough, fatigue, dyspnea. These all mainly the chest symptoms, as you know, okay? And then you have some neurological symptoms like some dizziness and headache. And then you have also some GI symptoms. Now, my talk is not about today, but we swiftly move on to the next slide, which is actually a very good description of how corona or COVID has involved so many systems. This is from Gupta, from the Nature. You can see, starting from the top, from the brain, you can have the neurological manifestations. Some of them can be as common as headache and dizziness, which are the common symptoms. And we'll talk about later on some uncommon symptoms or uncommon presentations of COVID, which are encephalopathies or GBS. We also know that we found that the neurological manifestations also had some like anosmia or agasia, and stroke is now thought to be not an uncommon, it's actually a common complication of COVID-19. You know that the kidneys can be affected as well, and we saw that lots of our patients who ended up actually in ICU had needed dialysis and CRRT. You will see that the patients will present with raised LFTs and deranged liver enzymes. You will see the patients will have GI symptoms like nausea, vomiting, diarrhea. Now, thromboembolism. We all know that this disease is very coagulopathic, and you have as common as DVT or PE or catheter-related thrombosis, and could have thrombosis in other sites as well, which we'll talk about. The common complications or extrapulmonary presentations of cardiac would be like something like MI or arrhythmias or even myocarditis, but we'll talk about the others as well. Then endocrine patients, as you can imagine, the patients will present with infections and infection leading to hyperglycemia or even DKA as well. You might have also heard of dermatological complications or dermatological presentations, famously known as COVID pose even as well. So this is a nice description of multi-systemic involvement of COVID. On top of it is neurological. So let's talk about the neurological uncommon presentations of COVID-19. This is a nice Lancet article which explains that how common or uncommon symptoms of COVID-19. Up to one of the patients who have COVID-19 might be presenting with neurological association. Now, that could be as common, as I said, with headache or dizziness or vertigo, or it could be as complex as 8 patients with encephalitis and 19 patients with GBS so far in the literature. Okay, you have also have on the bottom an AGM article from Jules Helms, who is also talking about 58 cases, out of which the patients who actually ended up in ICU did have diffuse corticospinal tract signs with upgoing planters, and they might have this executive syndrome as well. So how do we define encephalopathy, and how common and different descriptions of encephalopathy could be? Now, you all might be familiar with PRES. PRES as posterior reversible encephalopathy syndrome. We know that the PRES can be because of immunosuppression, can be because of systemic infections, viral infections as well. So there have been several reports. On the right, you can see that PRES associated with COVID-19 have been many more than this as well. This is a nice article, again, from Journal of Neurological Sciences, which showed 4 patients with COVID-19. And what it showed is that the patients were presenting with confusion and seizures. And the one common thing with them was that the hypertension. So if you control hypertension well, if they did not have labile hypertension, they might prevent these features, or they might prevent the progression of PRES as well. How do we see that? So this is our, this is, you can see in the PRES, what you will see in the subcortical white matter of both occipital lobes and the temporal lobes involvement. And that's the typical features of PRES. So this is encephalopathy, but involving the PRES, involving the posterior lobes, occipital lobe, and the temporal lobe. Let's move on to the acute necrotizing encephalopathy. This is not the term which most of us have heard of. So ANE. ANE used to be mostly associated with carbon monoxide poisoning, or some post-cardiac arrest, or even toxic overdose. Now again, ANE has been, there has been some reports of ANE as acute hemorrhagic encephalopathy, also acute necrotizing encephalopathy and myocarditis in a young patient. You can see some reports there. We ourselves had one case as well. We reported that in our hospital as well, COVID-19 associated encephalopathy. And what's the difference? The difference between what we saw in PRES and here, this is acute necrotizing encephalopathy. This loves the thalami. You can see the median thalami being involved. You can have involvement of brainstem. You can have involvement of cerebellum. But this is a gray matter and white matter disease. Over there in PRES, what the difference was, so the PRES was involving subcortical white matter. This is gray matter and white matter involving, like as I said, thalami, the brainstem, the cerebellum. Now, you might not be very familiar with this term, which is coming up, and you will see more and more, which is called DPHL. This is delayed post-hypoxic leukoencephalopathy. Now, we used to think that all the patients who end up in ICU and they then become agitated and confused, they might have a hypoxic brain injury. This is different from hypoxic brain injury. Hypoxic brain injury was involving the deep and cortical gray matter. In these patients, the gray matter are spared. So what we see that is, as you can see from the Journal of Neurological Sciences and American Journal of Neuroradiology reporting that this is our patient. What you can see is on the bottom here is diffuse severe disease on the CT, on the chest. On the other side, you can see it's asymmetrical, it's diffuse, it's white matter, subcortical, T2 hyperintensities with variable changes of restricted diffusion, as well as you can see on the bottom. Now, what we are seeing here, again, this is sparing the deep gray matter, but involving deep white matter. So another form of encephalopathy. So far, what we have seen, different kinds of encephalopathy, and mainly their description or their presentation could be similar, but they have different imaging features. Now, the GBS, as you all are familiar with, Guillain-Barré syndrome, again, Toscano submitted this in NEGM, 5 patients. The common thing was that 7 to 10 days of after onset of COVID symptoms, they were mostly tetraplegic. Their protein count was quite raised. Their MRI was normal. They were all given immunoglobulins with variable response and variable prognosis. So that's enough, I think, probably of neurological here. But we think that stroke is common. As I said earlier, stroke is common, and that could be association or confounding factor with COVID. But how about pica stroke? Pica strokes, here on this Journal of Thrombosis, again, you can see COVID-19 ischemic stroke. This is this is quite comprehensive study on stroke patients, which tells us we know that this is COVID is involving large vessel strokes. But a new thing which we are proposing or hypothesizing is that for some reason, the strokes are not only common, but they also like pica territory, posterior inferior cerebellar artery. Okay. Now, why they involve posterior inferior cerebellar artery, we have explained that's an article. We submitted this, as you can see, for American Journal of Neuroradiology. We had 6 cases. All of those 6 cases, you can see that they had presentation, mostly late presentation, even week to 10 days late of COVID symptoms. They had a few comorbidities. They had raised inflammatory markers, and mostly they had raised D-dimers as well. One of the most striking things is that they were given some sort of antithrombotics, whether they were in dual antiplatelets, they might be on high dose low molecular weight heparin, or even DOACs. Still, despite that, they got these pica strokes. So let's move on to something related to neurology, which is psychosis. So again, there have been different theories about psychosis and relation with COVID. Now, there's certain beliefs that maybe this is a grief reaction. Is it post-stress traumatic disorder? Is it because of you are thinking you're gonna get it and you get this psychotic episodes, where you can see on the bottom in the Lancet again, beautiful study on 153 patients where they observed the patients who presenting with acute psychosis, actually they had some delusions, some hallucinations. There were 10 of them. So we are submitting our cases, which are 3 cases we have observed, had no psychiatric history, had no COVID symptoms. They presented just with acute suicidal ideation and psychosis, and were found to have COVID, were found to have COVID on the CT as well. Okay, this is another interesting one. Now, we know, we talked about thrombosis and we talked about the DVT and PEs are common, okay, in our patients. But thrombosis can be anywhere. So we found this patient, so far as we know, his retinal vein thrombosis has not been reported. Now you can see one of our patients who is 40 years old gentleman who actually presented with COVID symptoms, with blurring of the vision and the DVT. Now, here's the CT, you can see on the right, okay, he's got moderate disease on the CT. You can see on the fundus, we found out he's got some cotton wool spots on the right eye. On the left side, you can see retinal hemorrhages. Okay, this is OCT, optical coherence tomography, which again confirms impending bilateral central retinal vein occlusion. Again, we submitted it and we're waiting. Okay. This is again presentation all together: COVID, pneumonia, DVT, and retinal vein thrombosis. Next is so GI. Okay, so there have been again some COVID presentations with bowel ischemia. You can see on the right. One of our patient who you can see the CT on the top, quite severe disease, and then he presented. This is a young lad which presented with multiple small bowel loops. You can see on the abdominal X-ray impending bowel obstruction, and then we did the CT, which showed non-enhancing jejunal and ileal loops, which were consistent with multifocal bowel ischemia with impending perforations. This patient was rushed to laparotomy, but this patient still in our ICU post-surgery and post-laparotomy. How about pancreatitis? So again, patients can present with some GI symptoms, could be abdominal pain, could be as an acute abdomen. Here's our case again in our hospital. We presented as an acute pancreatitis patient. This is what presented, and on the bottom, there's another case which we haven't submitted yet. You can see the CT showing bilateral bibasal infiltrates and pleural effusions, and you have tail pancreatitis with progressive necrosis and gas-containing lesser sac in the four weeks later CT as well. So you can see it afterwards as well, although it was the tail pancreatitis and it has progressed later on 4 weeks later. So again, a COVID presentation with maybe confounding factor or COVID-related pancreatitis. Now, moving on to endocrine. So we have few cases where they have presented with that as the other viruses like SARS virus and the other viruses have been noticed to have some effect on hypothalamic pituitary adrenal axis and somehow presenting as adrenal insufficiency. So we had another similar case and we submitted in BMJ again, again, this common COVID symptoms presentation, but found to have severe adrenal insufficiency. Now, musculoskeletal. Now, again, we know that this, as it can involve so many systems, it also can involve the musculoskeletal areas as well. So what it involves, it can cause inflammation. Now, on the right, you can see that myositis is manifestation of SARS-CoV-2. You have an article from VDON, and this is our patient who again showed diffuse bilateral symmetrical muscle edema of the pelvic girdle and proximal thighs, again presented with his hip pain and presentation of COVID symptoms and found to have this myositis on MRI.
Dr. Gaba, sorry to interrupt. You have 2 minutes.
Yeah, my last slide now. So I'll move on to the last slide. Now, I said that in the last, I said that in the beginning, that we will not talk about the pulmonary because we think that the pulmonary symptoms are COVID usual symptoms, they're common presentations, but can there be some uncommon presentations of pulmonary symptoms? Now, spontaneous pneumothorax, pneumomediastinum, spontaneous pneumopericardium. Again, we have seen more with the patients with COVID-19. Now, you can say that these could be secondary to having intubations, BiPAPs, but when you compare with the previous data, they were not that much. So here we have a patient also, one of our patients who presented with PE. You can see proximal segment embolus in the right upper lobe, and also in the lung windows, you can see the right anterolateral pneumothorax and some basal pleural effusion. So COVID patients, again, whether this is a confounding factor they had because they were intubated, but they have also been suggestion of spontaneous presentation of these patients association with. Here I will just stop. I think probably I'm done. So happy for the questions in there.
Thank you very much, Dr. Gaba. It's very exciting to know different presentations of COVID-19. Now we will move on to our next talk, and that is about a review of clinical trials for the treatment of COVID-19 and the post-hospitalization COVID-19 study, which is called PHOSP-COVID. So I'll invite my speaker, Dr. Neil Greening. He is Associate Professor at Institute of Lung Health, NIHR, Leicester Biomedical Research Centre, UK. He is a prolific researcher and has been actively involved in world's largest COVID-19 trial, which is Recovery Trial. Over to you, Dr. Greening.
Thank you very much, and thank you to KEMCA UK for organising such a fantastic World Symposium, and Dr. Mohammed Tufail for inviting me. Can you see my talk?
Yes.
Yeah, good. So thank you very much. I'm a clinical academic in respiratory and pulmonology, and doing a lot of our post-COVID follow-up as well as seeing a lot of the patients. So I thought I would do a quick review of some of the clinical trials that have been done and why the therapies we're developing are, and then a little bit about thinking about where we might be heading in the longer term. So why is it important? We all know that research is important, but one reason for having this World Symposium is actually we are having a modern day unique situation. I can't comment about what happened in 1918, but I can comment on what happened today, and worldwide, we've never seen this. And at the start of this, I think we have to accept that we had no good therapy for coronaviruses or actual good therapy generally for viral pneumonia. And when we come to that, research is vital to trying to find out, but also we want to do the best for our patients, and the natural medical thing to do is to give whatever therapy we can think of in the hope that it might help, particularly when people are very unwell. And actually, we've got to remember this might cause potential harm, but also may cause wastage as well. We may give very expensive drugs that don't do anything. I would use the analogy for idiopathic pulmonary fibrosis, where for 50 years we gave steroids before we did a proper trial to show that it killed people. We don't want that. So we want to do that. So we have to ensure that there's good evidence-based medicine. Trials are tricky in the acute setting, and tricky when you have a new condition. So I'm going to rattle through a few of the therapies that are covered that we're probably most of us have come across in some way or another, but also to think about what the evidence is behind them and where we go from there. Plus some of the post-COVID research, and particularly the PHOSP study, which is just recruiting its first patients last week. So when the pandemic started and I was looking around looking for therapies, people started to talk about remdesivir, an antiviral therapy, and this has been developed for a number of years for other coronaviruses. And this is perhaps where SARS-CoV-2 and therapies were slightly ahead of the game because of things like SARS and MERS. People had started to develop therapies for coronaviruses, and it doesn't require a lot of adaptation. In the wet lab, remdesivir showed a lot of promise. So this is, as you can see from this study, this is actually well before the SARS-2 pandemic, but was based on other coronaviruses. And you could see in the lab, actual viral loads were reduced dramatically when we gave therapy. So remdesivir in the wet lab looked well. More recently, there's been a SARS-CoV-2 rhesus monkey model, which seemed to suggest that there was clinical improvement was more likely in those with remdesivir. So these in the red here seem to have better clinical outcome than those with just the vehicle, so no drug seemed to do worse. So there was certainly evidence in the wet lab and in monkeys that remdesivir looked quite promising. So many of you will be aware of this because you will have given remdesivir for your patients, but it's important to look at the proper trial rather than just cohort studies. Remdesivir trial recruited 1,000 patients and gave either 10 days remdesivir or placebo. And as we can see from this graph here, this is proportion of patients recovered. Overall, remdesivir had a small effect at improving clinical recovery over placebo. And in terms of time to recovery, the group in remdesivir had about 11 days to a significant clinical recovery, as opposed to 15 days with those in the placebo group. What we do when we do look at which groups seem to respond, those that got oxygen seem to have a better response to those that didn't. Interestingly, those perhaps who didn't require oxygen but were not ventilated, so the milder patients, there was no significant difference, but that becomes trickier because, of course, there's less room for improvement. I think what became much more obvious was that those receiving mechanical ventilation or ECMO, we didn't see any significant difference. And these are better numbers, so you can see that there's 125 and 150 at the start in the ventilator groups. So remdesivir definitely seems to have a clinical role. The question is, how much of a clinical difference does it make? Doesn't help those that are the sickest, doesn't seem to help those not really needing oxygen, but those needing oxygen, perhaps a little bit of improvement. So remdesivir is a clinical treatment which we are giving and worldwide is being given. Do I think it's a game changer? Unfortunately, probably not. There was also another study just in question about number of doses because we're running out, and they just compared between 5 days and 10 days in the New England Journal, and they showed that whether patients who got 5 days didn't seem to do any worse than those received 10 days. So we can see here this on day 1. By day 5, they divided them up here, and by day 14 they looked at them, and the 5-day group didn't seem to get any worse. So it seems to be an early effect that the remdesivir has rather than a prolonged time to take. If we move on to other antivirals, things like combination Lopinavir and Ritonavir was initially thought. It came out very quickly because these are drugs that are easily available and already in circulation, so they can be done. And this trial of 200 patients, an open label trial, didn't show any difference. So I won't go into it in great detail, but they didn't see any difference in time to improvement between those that received the antivirals and those that were controlled. One of the hopes of Lopinavir and Ritonavir is that perhaps you could give it very early and it might reduce viral load, but unfortunately this was measured in this study, and as you can see, there was no difference in viral load. So it doesn't look like we could use this to reduce the infectivity of it. Just because this is only 200 patients, this paper isn't out yet, but it has been reported. So the recovery trial, which I'll discuss a lot, is the national UK trial. For those of us on the call in the UK, we have to be very proud of our recovery trial. We have recruited 12,000 patients across the UK into proper randomized controlled trials where people go into different arms. And we are the only country where this is being done on a really good national level. And the fact that we've recruited 12,000 patients just shows how accurate it is, but it also means that we've got power to test lots of different therapies against standard of care. So just the Lopinavir-Ritonavir was an arm in recovery. 1,600 patients received it, and just over 3,000 received standard care. And this was powered to mortality, which you can do with these large numbers, and no difference in mortality was seen. And actually, it doesn't appear that any difference in progression to mechanical ventilation or length of hospital status. So the recovery trial, which hasn't formally reported this yet in a paper, has shown a negative trial. So I think we can safely put to bed Lopinavir and Ritonavir from 2 different trials now. I'm pleased to say Donald Trump isn't on this call, but the hydroxychloroquine plus minus azithromycin has been by far the most controversial treatment for COVID-19. And this is down to people mentioning it, presidents saying that they are taking it. So there has been a lot of widespread use of this without good evidence. There was also a large trial published initially suggesting harm with hydroxychloroquine. I'm not going to cover this because the trial has actually now been withdrawn due to concerns of the data integrity, that data had been bought. So I'm going to completely ignore this trial because I don't think we can trust it. So what have we got? Well, at least we have got some trials. We've got a trial of 504 patients, again a New England Journal publication, who had confirmed COVID-19. So these weren't just people with a clinical syndrome, but they were swab positive. And no difference was noted in those who received hydroxychloroquine, whether or not you used azithromycin with it. So it's not often you see a p-value of exactly 1 for both, which can tell you quite safely that it didn't work. And if we just look at clinical improvement, we can see that those in the control were completely the same as hydroxychloroquine alone or hydroxychloroquine plus azithromycin. So this trial of 500 patients showed no difference with hydroxychloroquine. Just to back that up, and again, if I use the recovery trial, again, they have demonstrated the results, but not fully published in peer review papers. So these are just the headlines. They recruited 1,500 people to receive hydroxychloroquine, 3,000 people to receive standard of care. And again, absolutely no difference in 28-day mortality. So 25.7% in hydroxychloroquine, 23% in standard of care, no difference. And if you look at things like hospital stay or other measures, they've reported no obvious difference. So again, I think we can put hydroxychloroquine as an acute treatment to bed. So we've got one that works a little bit in remdesivir and 2 that don't work. The other question, and I apologize I haven't got the reference, this is recently out in the New England Journal, is post-COVID-19 exposure. So if I were a public health physician, I wouldn't want to just treat COVID, I would want to stop the spread and stop people getting it. And there was a question on whether giving hydroxychloroquine early to people, much like in TB screening, whether we could pass it, prevent it then being people developing it and passing it on. And so they found 800 patients who were acutely exposed to COVID-19 clinically, and people were given hydroxychloroquine within 4 days. And you can see here that about 11% of the patients went on to develop symptoms of COVID. And actually, if you look at day 5, day 10, and day 14, there's no significant difference in going on to develop symptoms. If you want an absolute rate difference, it was only 2.4%, but this is not clinically significant. So I wouldn't be giving hydroxychloroquine to people as an exposure prophylaxis. Unsurprisingly, hydroxychloroquine did result in common side effects, with 40% of people reporting side effects compared with 17% for placebo, although these were not severe. So I think hydroxychloroquine has probably had its day. Now, coming on to dexamethasone. And I remember when we started dexamethasone in the recovery trial, I confidently, and so did some of my colleagues, say there's no point in doing this, but we're just doing it because it's cheap and readily available. But the theory goes that we've concentrated mainly on antivirals so far. But as many of the talks have talked about today, this massive inflammatory response that we see and that kills people, we might want to give a treatment to treat the anti-inflammatory. So the question is, does giving a steroid be effective at reducing a large inflammatory response? And the intensivists amongst us, amongst this group here, will know that there's some evidence in ARDS. It's been very controversial for, many years. Every conference I go to, you could have a debate on it. There's been some recent work out in Lancet Respiratory that looked more promising. And actually, if you go to the systematic reviews, probably low-dose steroid might have a role. High-dose steroid, I think doesn't have as much evidence, things like methylprednisolone, and could potentially worsen infection. So the recovery trial, and this has been published in the New England Journal, gave low-dose dexamethasone, 6 milligrams a day for 10 days. And the results are astounding and fantastically positive for such a cheap, easy-to-access drug. So in all comers, so this was a trial of 6,000 patients, which is so impressive when we look at everything else. We can see that mortality at 1 month was 25.7% in the placebo group, but 22.9% in those that received dexamethasone, which we can see in this trial here. So dexamethasone reduced mortality. So this is our first trial to show reduction in mortality. What's also really nice about this is that we see a dose response. So these are hospitalized patients. And we can see that those with oxygen, which comprised of just under 4,000 of the patients, there was still a significant difference, but it was similar to the old, because this is the large number of 23 versus 26%. But those with the worst systemic inflammatory response, those that are ventilated, there was a much, much bigger response. So in those that received steroids, just under a third, 29% died, compared with 40% that had been ventilated otherwise. So what we're seeing here is a dose response and a real response against the inflammatory area. So those that are ventilated respond the best, those that receive oxygen do respond. And of course, when you're looking at an overall effect, if you see a better response one way, that means you must see a worse response the other way. And we've just got to be aware that those that had mild disease and didn't need oxygen, actually, whilst it's not statistically significant, dexamethasone certainly didn't do any good. And there's a little bit of worry that it might do worse. So we've got to be careful with dexamethasone. It's absolutely a first-line drug, and the moment someone needs oxygen, I would be giving it. In those that don't need oxygen, actually it might increase your risk, and you might worry about the harm of things like diabetes control with steroids. So dexamethasone is not for everyone, it's for those that need oxygen, and absolutely those needing invasive ventilation. So I think this is a really interesting trial, and just stunning that such a cheap, readily accessible drug makes such a big difference. If we now move on to some areas which perhaps have a little bit less evidence, convalescent plasma has been around for many years. People have done it, and people have done it for many different conditions. And it's very easy to do. The idea here is that you take the antibodies that someone's got, so positive, someone who's recovered from COVID-19, isolate their antibodies in their plasma, and give it to people either as prophylaxis for exposure or as therapy, as an antiviral therapy in those that do it, and see it. And there have been some small, mainly case series and retrospective data in other conditions that this may be effective. So this was a trial done in China. It had initially planned to recruit 200 patients. Both fortunately and unfortunately, by the time they got to recruit 100 people, there was no more positive COVID in Wuhan. So they actually had to stop the study when they'd only recruited half the patients because they ran out of patients. And as a result of that, we're a little bit lost in lack of power. What we can say absolutely is that giving convalescent plasma reduces your viral load. So what we can see here is those with negativity rate in those that receive convalescent plasma by 72 hours is up to 87%, whereas a control group at 72 hours, that's only 37%. So absolutely convalescent plasma is reducing your viral load. Does that lead into clinical improvement? Well, not significantly is the answer. So those that improved in the plasma group took 28 days to recover. They couldn't work it out for the control group, but there was no obvious difference. What I would say is that there did seem to be some effect in those with severe disease, so needing oxygen, but not those who were ventilated. In ventilated patients, it seemed to be too late and absolutely no difference would do. So I'm interested, so I think the jury is still out with convalescent plasma. I'm really interested in this as an earlier treatment, perhaps not in ICU, but to prevent people developing that so we can reduce viral load. But we need the trial to come out for this. And I've already talked about the recovery trial, but convalescent plasma was a later addition to one of the arms. So I do hope that we see that. So if we move into other trials, tocilizumab, which is an anti-IL-6, has been freely given actually, and if you look into the literature in the US, I think it's been given to more patients than not, we know that IL-6 is a massive inflammatory cytokine and is always associated with poor prognosis, both in COVID, but other conditions as well. So if we look at how dangerous and chances of mortality, a raised IL-6 is by far the most accurate. We can see that those who don't survive have a higher IL-6 value than those that do, and we can see that it rises as people come unwell. The question is this just a biomarker or is it a genuine mechanistic effect? So we could reduce the systemic inflammatory burden with tocilizumab, but the question is, does that actually change prognosis, or are we just targeting a downstream cytokine? Tocilizumab itself binds on the receptor to block IL-6, so it doesn't reduce IL-6 itself, it reduces the interaction with its receptor. So I'm not going to go into lots of the trials because if you go into the literature, there are multiple case series and cohort studies of tocilizumab, and it's clearly been given widely across countries. But I would argue it's impossible to draw conclusions with any of these cohort studies. They generally don't have a matched cohort. If they do have a matched cohort, it's usually for reasons. And I worry about observer bias in giving tocilizumab. So there are 2 or 3 trials of tocilizumab, and the results aren't yet out, but the COVACTA study, which is one of the largest randomized controlled trials going, the full trial results are awaited, but they have done a stock market release. So for those of you that are involved in commercial trials, you know that the companies will always release the headline figures to the stock market before published for licensing reasons. So I went to the stock market release, and they have stated that the primary endpoint has not been met in the COVACTA study. So they have seen no significant difference, p-value 0.36, with an odds ratio of 1.19 in terms of primary outcome. They've seen no difference in mortality at 1 month, so 19.7 versus 19.4%. There was a shorter time spent in hospital compared with placebo, 20 versus 28 days, but no difference in ventilator-free days. And rates of infection and rates of serious infection seem to be similar. So I'm awaiting the full peer-reviewed publication of this, but the COVACTA study appears to predominantly be negative. So we'll see what the other randomized controlled trials are, but this is not something I would be routinely yet giving in my clinical practice. I would rather give tens of thousands of people dexamethasone than tocilizumab. Just to move on, and I'm going to move away from the drugs slightly, and this is me going against my area. This is my advice of always going for the randomized controlled trials. This is a very recent cohort study, but I just thought it was interesting because I think we sometimes forget there are things other than drugs and medications out there, and this was proning of non-ventilated patients. So there's excellent results of proning in ventilated patients. The question is, can we do it? Well, in this cohort of patients in, I think it was Italy, they prone people. 87% of people were able to be prone for more than 3 hours comfortably, so they worked very well. And we can see here in the patients that were proned, oxygenation and ventilation improved. So we absolutely saw an improvement in ventilation, and once moving them back from prone to supine, about half of them maintained their improvement in oxygenation, but a half went down. So the question is where this fits clinically. You can obviously get a temporary effect with proning patients in the non-mechanically ventilated patients. Does it offer long-term benefit? I think that's where the next question is. Does it genuinely make a difference, or are we just improving the numbers? So I've concentrated mostly on COVID so far, but as we've discussed, post-COVID is becoming a real thing, and I run a weekly clinic following up all our patients who've been in with COVID. And the UK, again, is hopefully going to lead the way on this and has a nationally set up study, which I think 55 sites across, or 55 hospitals across the UK have agreed to take part in, which is called PHOSP. And the idea is we don't know what the long-term consequences of COVID-19 are. We know that SARS had a high prevalence of pulmonary fibrosis, but as the previous talk goes, there's lots of non-pulmonary effects. So we've seen lots of myocarditis, we see huge amounts of fatigue and mental impairment, and there may be even worries around things like direct cognitive impairment to the brain as well. So the FOSP study will be aiming to characterize these many aspects. So just to go with that, FOSP, and for any of you in the UK, I'm almost certain your sites will be involved, will involve following up people. And we have different levels so we're hoping that everyone who comes to hot follow-up, so 10,000 people will be followed up in tier 1. And this is about using medical records and hopefully getting some genomic data and transcriptomic data, seeing if we can identify why people got as sick as they did or who did very well. Tier 2 will be following up other areas, and that's looking at things like sarcopenia, psychological impact, cardiac involvement, renal involvement. So a more in-depth phenotype of 4,000 to 5,000 patients. And then for the real experimental stuff, we're going to call back a few people into what we call tier 3, and that's where we'll be doing things like interventional studies, looking at real in-depth things like cardiac MRI, whole body MRI of brains and other blood vessels, looking at myocardial and skeletal muscle impacts, and seeing if there's something we can do. And this is also linked with the Azaric cohort, which is their laboratory, so we'll be working well, so we'll have things like saliva, and we can link directly data with the Azaric cohort, which will be a fascinating follow-up, because we'll get a real idea of the genomics of a pandemic, which will be, of course, never have been done before. So I've covered a few therapies here. Remdesivir, yes, but not got to give this. I think it has some clinical benefit. Dexamethasone, absolutely. Not Lopinavir-Ritonavir or hydroxychloroquine. I think the jury's out on convalescent plasma, and I'm interested to see what that does. I'm yet to see any convincing evidence for tocilizumab, but I'll await other trials and the full peer-reviewed publications. And I think proning in non-ventilated patients is interesting. Again, I want to know what the long-term consequences. Does it really prevent people going to ITU or not? So in summary, research and well-conducted evidence is really essential. We want to improve outcomes for patients, and the only way we can do that is to change our therapies. You absolutely need great infrastructure and collegiate work. And that's something we've really learned. There's a lot of goodwill out there for the pandemic, but you've got to have it in a joined up way. If the United States had it together, they could have recruited the whole of the recovery trial in a day. And they haven't. So we need to really deliver on these things. And then the long-term consequences of COVID-19 will be fascinating, because I think it will shed light not just on pandemics and coronaviruses and SARS-CoV-2, but really give us real insight to post-viral illness and also post-ICU and hypoxic settings. So I'm going to finish there now, and I want to thank KEMCA UK again for inviting me to talk. Thank you very much.
Thank you very much, Dr. Greening, for giving us an overview of the different clinical trials. It's very hard as a physician to gather all the different scattered evidence and clinical trial data and information, and especially mentioning about the PHOSP-COVID study as well. Thanks again. So third talk is about lessons from critical care and when to use ECMO. My speaker is Dr. Asim Siddique. He is Director Critical Care Unit, Baylor St. Luke's Medical Center. Is also an assistant professor at Baylor College of Medicine, Houston, USA. So, Dr. Siddique, you can share your slides now. You have 20 minutes for the talk.
Thank you so much. Thanks for the KEMCA for arranging this talk, and thanks for inviting me. Can you guys see my screen?
Yes, we can see that. You can start now. Thank you.
So I'm just going to go through the lesson learned for critical care and timing of ECMO. I work at Baylor College of Medicine. I'm the director of their ICUs, as well as chief of critical care for one of the children's hospitals. I don't have any disclosures. Just a minute about TMC. It's one of the largest medical city in the world. There are 3 medical schools, and then there are more than 10 million patient encounters. We have about 9,200 patient beds and more than 100,000 employees. Baylor shares about 1/3 of that. We have seen about 18,700 cases so far, and currently about 1,600 are still hospitalized. We have discharged about 15,000 cases, and our mortality was about 8%, and our vent mortality ranged between 25 to 35% in different hospitals. We were the center for almost all the trials, whether it's vaccination, whether it's Remdesivir, Covecta, and multiple others which are ongoing. US in general and Houston specifically peaked late, so when you guys were just coming down in terms of your surge, that's when we were just peaking. And we had our surge peak in mid-July, and as of right now, as you can see in the hospitalization, we're going down. This is the admission to the ICUs. Again, we peak in mid-July, and currently it's going down. And this is the TMC. We have created about 2,500 bed capacity. Currently, we have about 1,400, and we also set up a 250 bed temporary setup in one of these stadiums if we have to use that. Luckily, we did not have to. So back to my talk, I'll mainly talk about the escalation of the respiratory support modalities, mechanical vent support, ECMOs, and other innovation. And if I get some time, I'll talk about comorbidities in the critically ill COVID patients. So this is one of our patients, and we have seen numerous of those, 45 years old, prediabetes, hypertension, presented with fever. In the ED was tachycardic, tachypneic, hypotensive, desaturating. Physical exam except moderate respiratory distress was okay. Leukocytosis, some lymphopenia, and then AKI. Was placed on airborne and contact isolation. SARS-CoV came back positive. Patient was started on Decadron. We'll talk about in discussion, but our center was using steroids early on based on different ARDS trials, and the patient was enrolled in remdesivir trial and placed on COVID floor. This was the X-ray. Again, it shows ground glassing on both sides, and the CT shows the same thing as well. Most of you guys have seen this cartoonic description of the two phases. One is the viral response phase, and the other is the host inflammatory response phase. And most of the time in the ICU, we see patients in stage 2, and then some of them get better. Lately, we've seen most of the patients are getting better, and some of them just go into the stage 3, which is the hyperinflammatory phase, and then they go into ARDS and cytokine storm. This is Baylor St. Luke's escalation of oxygen protocol. We start with low flow oxygen. When it gets to about 6 liters, we think that the risk of fertilization is very high. And then we switch to non-rebreather and then transfer to a step down or the ICU, where we use high flow nasal cannula, helmet ventilation, and we'll talk about that, or mechanical ventilation. So just a few words about low flow. We use maximum 5 to 6 liters. We avoid humidification. And just as the talk previously, we're using 85 to 90% of our patients are awake proning. We're just putting our data together. Hopefully we'll publish that soon, and then try to avoid hyperoxia. I won't go into detail because you just have seen the numbers, but it just improves the oxygenation. Our experiences that we are able to avoid some of the ventilation requirements because of this, but we're just waiting for the final data to prove that. This is how awake proning is done. We use these wedges, and then so that we can reduce the skin injuries as well. Back to our patients. 6 hours later, patient is on oxygen, self-proning, still tachypneic, still tachycardic, and was worsening, so we switched to and was started on heated humidification. Now, we received some of the labs back, and we have platelet aggregation in TEG, which was high. We have published some data on that. And then patient D-dimer was high, CRP was high. So patient was started on anticoagulation as well. Now, the question is what to do, how to step up when you're on nasal cannula. So there are 3 modalities which are available. One is BiPAP, the other is Vapotherm, and on the right is the helmet ventilation. So traditional face mask, non-invasive pressure ventilation is generally avoided because of the risk of fertilization. The benefit is unclear. In our institution, we only use it if someone is palliative care or patient declines intubation, and we use it in negative pressure room. There is highest risk of fertilization if you're on nasal pillow. In terms of heated humidification across US is widely accepted. It's in COVID guidelines as well. The aerosolization is minimal if you wear the mask, as shown in one of the study in Respiratory Journal as well. And it improves the oxygenation. We use higher flow, and then that also creates a PEEP, which is almost every 10 liters create a PEEP of 0.6 to 1. There is decreased anatomic dead space. There is decreased metabolic cost of breathing, and that results in improved work of breathing. There's better excretion clearance as well as superior comfort as well. How to do it? It's all about flow. What we do is we keep the flow at max, what the patient can tolerate between 40 and 60 liters, And then bring the FiO2 down to as low as you can, and then adjust the temperature to patient's temperature. Now, initially, there was this concern about how much is the aerosolization. So if you look on the top, there is high flow nasal cannula, and if you wear the mask, the aerosolization is almost the same as the low flow oxygen. But if we don't use the mask on the patient, then the aerosolization is obviously high. Our patient declined on high flow nasal cannula, still was worsening. So we decided to escalate it to helmet ventilation. And again, this was based on our protocol as well. So helmet is actually manufactured at a place very close to where we are. It's a venile hood. You have a neck ring, which is silicone. You have in and out ports, and how to use it. So you can use it with ventilator. That's what we do. You can use it with wall oxygen or flow. And the next one is BiPAP. You set it up at PEEP of 5 to 10, improve the flow, and then after that, you just strap the patient so that it's secure. And then you just reassess the saturation as well as the work of breathing. And if patient does not get better, you increase the PEEP. We use between 10 to 12 in terms of PEEP and inspiratory pressure, up to 10 to 12 on top of that. And if the patient does not get better, then we just escalate to mechanical ventilator. We mobilize patient on helmets. We also, help them stand, walk around. If they're able to take breaks, then we take the helmet off, put them on high flow oxygen. And then if they're not able to eat, we can use nasogastric tube or the Dhabi tube for feeding. We had some patients who were able to stay on the helmet and improved, so we don't have to use mechanical ventilator, and the weaning parameters are the same as for mechanical ventilators. One of the warning is that there is no exhalation port, so there has to be a constant flow of air, otherwise patient can have asphyxiation. We don't have as big studies as recovery trial, although I think after COVID, there will be some coming from our center as well. But are studies in 2016 where the primary outcome was endotracheal intubation. The N was very small, but there was significant difference between helmet and face mask. This was the improvement in the survival. And then this was a meta-analysis which was published in 2016 as well, which was based on hospital mortality, intubation rate, complication, and everything favored helmet ventilation. In our patient, in spite of helmet, patient got worse, and we have to intubate patient, place it in mechanical ventilator. We use Flolan pretty regularly in most of our hypoxic patients because the patient's P2F was very low, the patient was paralyzed, as well as prone on the ventilator. The question always comes to intubate early or to intubate late. During the first mini surge that we have, because we're not, too familiar with the COVID, we were intubating early, and there were all these guidelines from the US societies to do that. And then you probably have seen this from New York, where most of the healthcare nurses were saying that people are just killing these patients because they're putting them on the ventilator and causing trauma. But nowadays we're intubating late, we're putting patients on vapotherm helmet, and a lot of patients can survive without going on the ventilator. Is COVID ARDS a new phenotype? There are early reports that there may be two phenotypes. One is L, one is H, which is based on compliance. There was some data from John Marini and Italy where they talked about the ventilator strategies for that. But there are studies after that which suggest that it's more of a spectrum, and it's really hard for us to differentiate which phenotype the patient is. So most of the US societies and our centers, what we do is we just use ARDS guidelines, which is low tidal volume, low driving pressure, and the titration of PEEP to meet each patient's need. This is our ARDS hypoxemic protocol, which is also relevant to COVID ARDS. If you're in mild ARDS, we use non-invasive strategies. If you're in moderate to severe ARDS, they're placed in a mechanical ventilator. We optimize the PEEP. We look at the P2F ratio and the saturation, And if the P2F is less than 150, they're sedated, they're prone. We consider paralysis, lung recruitment maneuvers, and if their P2F is still low, then we consider them for ECMO. Now, back to our patient. Patient was still hypoxic, was prone. The next day when he was supine, patient was desatting because this was single organ failure, young patient, minimal pressure requirements, no RV dysfunction. The patient was on the ventilator for only a few days. ECMO consult was initiated and the patient was placed on ECMO. Patient's RESP score, which is one of the scores that predict survival, was pretty good, and there was 80 plus inpatient survival. Now, this is the TMC criteria for ECMO. Again, you have either hypoxic, which is majority of it, or hypercapnic respiratory failure. Age less than 60. We've only done one patient who was more than 60 because the patient was a good candidate, but this is kind of a rigid criteria. They meet the hypoxemia criteria. The duration of the mechanical ventilation should be less than 7 days. Single organ failure, there is no contraindication to ECMO, and the RESP score should be in the range where their survival is 50+%. This is from ALSA registry, which we are a part of. If the P2F is less than 150, you optimize medical treatment. And then in spite of that, if the P2F is less than 60 for 6 hours or less than 50 for 3 hours, or patient is hypercapnic acidotic, then you look at whether there is a contraindication to ECMO, and if there is none, then the ECMO is recommended. And the same thing for CO2 and pH. There are multiple contraindications to ECMO because it's a very expensive treatment, and there are only limited availability of it. In all med center where you have 2,500 ICU beds, we only have 100 ECMO capacity. Most of these are related to what is their expected life expectancy, and there is some relative contraindication as well. Now, when they're on ECMO, what you do is just standard respiratory management, which is low tidal volume, optimization of PEEP, low driving pressure, minimize radiology, and then therapeutics based on whatever is evidence-based for the COVID-19. Try to keep their hemoglobin between 7 and 8, platelets more than 50,000. Most of these patients are on anticoagulation, and we aim for a PTT between 50 and 70. They're started on enteral nutrition if possible. And then there is a perfusionist who monitors the ECMO circuit. Now, this is from ALSA registry, which is for the across the globe. So far, there are 26 confirmed cases of ECMO, and there are about 55% survival. In North America, it's about 1,340, and then that's what I'm going to talk about next. Out of 1,340, the median age was 48. Most of these were male. The intubation to ECMO, which is very vital, is 79 hours. It's about three days and a few hours. And that is very important, as we have done in our center as well, that you should put them on ECMO early. There was only one patient which was placed at about day 7 or so, and then we felt like there was, the outcome was not that good. Most of these are because of respiratory failure, and majority of them are VV ECMO. There are only 3% in the ALSA registry, which is VA ECMO, and that just entails that they have some cardiovascular compromise as well. If you look at the comorbidities, they're not significant. Asthma, diabetes, obesity, there's no organ failure, which would decrease their life expectancy as well. Now, ECMO run, 321 hours, it's roughly about 12 to 13 days, and we have seen some complication in our center as well. It's mainly related to bleeding because all these patients are on anticoagulation. In our center, we have about 30% patients who ended up with renal failure, and about half of them ended up on renal replacement therapy as well. And again, in US, the survival was about 54%. The length of the hospital admission was 29 days. And in our center, we have done about 100 ECMOs across TMC. Our survival is about 52%. Our patients were slightly older. They're about mid-50s. And then we have slightly less in terms of male to female ratio. I would just briefly talk about complications. So most of these patients would survive the respiratory component of it, but then they'll die from something else. Or there are some other comorbid conditions that happen. Renal failure is very common. Liver transaminitis or cholestatic picture is very common. ID, because we were center for tocilizumab, although we don't know because it was a randomization, we have tremendous number of fungal infection, aspergillus, and a lot of others, including CMV, pneumonitis, CMV, colitis. So again, you have to be vigilant so you can pick it up early and treat. Coagulopathy is very common. Most of these are prothrombotic. We have published some studies on it, and most of our patients are on anticoagulation, which is subtherapeutic, either with Lovenox or DOAC or heparin. As Dr. Gaba mentioned, delirium, encephalopathy, encephalitis is also very common in cardiovascular. There are multiple studies from circulation and heart failure. In our center, we're seeing between 20 to 30% of the patients cardiomyopathy or myocarditis. And then some of that does recover after the patients get better, but some of these people may go into chronic systolic heart failure as well. So back to our patient stayed on the ECMO for about 12 days, was decannulated from ECMO standpoint. It was a very slow ventilator wean because patients like this, they're developing fibrosis, and then a lot of these are going to the...
Sorry to interrupt, Dr. Asim Siddique. You have 2 minutes left for the presentation. Thank you.
Thank you. And then patient was seen in the clinic and actually is doing well. Now, I'm just going to talk about some other lessons which are learned from critical care as an administrator. One, it's a novel disease, and being anxious, being scared, being frustrated is normal. We don't know much about it, and we can't save everyone. I mean, in the US, people talk about all these experimental therapies and how we should use it so that we can save everyone. Don't use any medication which is on the news, as there was this push to do hydroxychloroquine because it was coming on the news all the time, and stick with evidence-based medicine. If you have to use agents, be part of the clinical trial. Nebulization treatment, we don't use it anymore because of the risk of aerosolization. Create PPE sterilization, extended use, reuse protocol as well because they're limited supply. We have implemented face shield for all the healthcare workers to decrease the risk of infection. Create code blue teams and processes to decrease the risk of exposure. Use automated CPR devices like Lucas device to decrease the exposure. Physician and nurses are very precious commodities, and the burnout is extremely high. Just a quick slide, we did employ COVID screening, and this is kind of pretty standard now across US. Asymptomatic carrier was pretty high, and then we implemented where the errors are multiple, like face mask, face shield, and 95 in all the ICUs. We're sitting around 4% for asymptomatic carriers, but the trend is good. This is our inpatient mortality. Non-COVID, it ranges between 2 to 3%. And 529 is where we have the surge, and COVID is about 10% recently, and vent mortality is about 39%. We've done some innovations. On the left, we have portable ultrasound, which is now standard in all COVID ICUs. We have brought all the pumps out to decrease the risk of exposure. We have brought the ventilator out to decrease the risk of exposure. This is the trach set to decrease the risk of exposure. There are hoods that we created for patient transport, for intubation, and for bronchoscopy. And my last slide is, this is what everyone goes through, their emotional highs when everyone feels like they're a hero. There's a honeymoon phase, but most of us are in disillusionment phase in US because this is a prolonged surge for us, especially because the lockdown is not there. I think for the sake of time, I'll just stop this and this is the references, and we'll answer any question during the discussion.
Thank you very much, Dr. Asim Siddique, for an excellent talk. Now I will hand over the session to Dr. Rana Rehman, who will be chairing from now onward. He is consultant in anesthesia and ITU at Tameside Hospital, Manchester. His special interests are ITU and medical education. Over to you, Dr. Rehman.
Thank you very much, Abdullah, for moderating. And we've already introduced speakers. We have got other panel members. I will have a co-chair, Dr. Majid Mushtaq, with me, who's a Chemcolian and a member of KEMCA UK. And he's a consultant respiratory physician and invasive pulmonologist working at Darrent Valley Hospital, Dartford. And then we've got Dr. Mohammed Fateh Shehzad, who is a Chemcolian and currently working in internal medicine special and in Ephraim McDowell Regional Medical Center in Danville, USA. And he is also Secretary of KEMCA 2020, and he's advisor for young physicians for APNA 2020. And we've got Dr. Mohammed Tufail, who is chairperson of KEMCA UK, and he's a consultant pulmonologist and works in Leicester. We've also got Dr. Talha Munir, who is a consultant hematologist working at St. James's Hospital, Leeds. Right, so with that, I would like to start with questions. The first question I would like to ask to Dr. Waqar Gaba. This was a question asked by one of the participants, Padmavati, that it was nice, I mean, that you have presented a lot of people with different presentations of COVID. But how do you say that these presentations were actually due to COVID and not necessarily that they were just presenting with these presentations like, I mean, encephalopathy or cardiomyopathy? Is that just on the basis of that they have got coexisting COVID?
Thank you, Dr. Hafeez, for the question, for the nice question. I have to say it wasn't easy, okay? You can't say it's easy to, because you have a presentation and you have ongoing pandemic, so you can relate it with the COVID. The advantage, you can say, we are a tertiary hospital. We were treating every patient who was coming through our doors as COVID. So as a standard, everybody who was coming through the doors was getting the COVID PCR testing. As a standard, they were getting some sort of imaging, mainly the X-ray, just X-ray, but also I think probably we did loads of HRCT on the beginning in ED as well to find out whether they had underlying changes of COVID or not. So that helps us in those patients who, although presented with different symptoms and signs, which were not related to the COVID, but raised our suspicion of COVID, and that could be confounding factor or could be complication related to COVID.
Thank you very much. My next question to Professor Greening. It was very nice detailed presentation, and we obviously have kindly identified that the only treatment which we can say for sure works is dexamethasone. And in the recovery trial, we used it for 10 days. The question from Dr. Gaba and also from Dr. Farooq, that is, will there be any role to continue dexamethasone beyond 10 days, say for up to 4 weeks, 6 weeks?
Yeah, thank you very much. I think that's a really good question. Actually, I think that Dr. Asim is right. This depends on what's happening. So in critical care, I would agree, we're seeing a large number of fungal infections and other infections as well. So I think the question might be, if someone is not responding, is it because of the COVID pneumonia, the inflammatory response, or because they've got a secondary infection, such as a fungal infection or secondary bacterial ventilator-associated pneumonia? So I think that's tricky. My gut feeling is that I would stick to 10 days rather than going for a prolonged period, but that's mainly because I worry about longer term infections. I think the other question is that if you are not responding within 10 days despite of therapy, what your long-term prognosis is. As was stated, we are unfortunately not going to save everyone. So at the moment, sticking with 10 days, I think it would depend on the individual in front of me.
That's very kind, thanks. Just a follow-up question. I mean, we had an observation that I work in intensive care and did not really see many patients with COPD coming with COVID. I don't know, what is your observation?
Yes, well, for those that know me, my genuine interest is COPD. I am a COPD academic. I think the reason you didn't see them in intensive care is that people don't respond haven't been referring people with chronic conditions to intensive care. I think that's bias. I think despite the chaos study many years ago, there is a lack of wanting to refer people, critically unwell people with COPD. We have still seen people with COPD in. There was some early evidence in China that perhaps asthma and COPD may be slightly underrepresented in COVID.
Yeah.
And there have been questions on why that might be. There's actually a trial just starting up looking at the potential benefit of inhaled corticosteroids to patients with asthma and COPD on inhaled corticosteroids. Could that have a small effect of preventing progression? We'll wait and see. My gut feeling in intensive care is that unfortunately people are quite nihilistic with COPD.
So we are the bad guys, yep. Thank you very much. Thanks a lot. My next question is to Dr. Talha Munir, who is a consultant hematologist and works at St. James's. We have actually seen that, and has been labeled that coagulopathy is one of the main reasons how obviously we see the complications of COVID. Can Dr. Talha Munir explain what is the difference between coagulopathy and which is induced by COVID and other coagulopathies? Dr. Talha Munir, please.
Many thanks for asking that question. I think the main issue that we're seeing in our patients with COVID is that there is initially an hypercoagulable state, and it feels like the patient has got DIC, but actually the patient's fibrinogen, if you monitor the class fibrinogen, is very high. So this is not a consumptive coagulopathy. You have got very high fibrinogens and very high D dimers. So there is high coagulable state as well as fibrinolytic state induced by COVID. And this is something which is called, instead of a DIC, it's kind of getting a name called immune thrombosis, primarily in the pulmonary vasculature. The patient's platelet count are actually normal or high, so thrombocytosis is seen in these patients. And we're seeing that the plasma protein levels are very, very high initially. So it is a feature of COVID that it induces inflammation primarily in the pulmonary vasculature. And there's been lots of calls that we receive that heparin is not working, or low molecular weight heparin is not working in these patients. And these patients are needing higher doses of anticoagulants to keep them at a reasonable anticoagulation state. And part of that is that because heparin is a negatively charged molecule, and you've got a lot of plasma proteins which are positively charged, you get a very high consumption of heparin in these patients. So some patients are needing very, very high levels of heparin, which is called as heparin resistant. So it is very different to DIC, what we see in initial phase. Later on, when the things go into really, really bad phase, you see classical DIC, you see a lot of consumption. Obviously, in that state, you have got more of a bleeding phenotype that happens really quite late on. Whereas in the hyperinflammatory state that we see initially, there is more coagulable picture at that moment in time. And there are, I think there are some trials looking at this question of low molecular weight heparin being used at a prophylactic dose, or you do a higher dose, which is kind of an intermediate dose, and in some patients where you need the full dose. That is all dictated by individual patient, individual parameters. So definitely very different to what we see in our normally DIC bleeding patients, is what we're seeing in COVID.
That's very kind. Thank you very much. My next question will be to Dr. Fateh Shehzad, who is working in USA. We have seen a lot of patients who present, who maybe have coexisting diseases like ischemic heart disease, hypertension, and can be on ACE inhibitors and ARBs, and how the practice is changing now. Can you kindly explain?
Okay, thank you. Assalamu alaikum. I appreciate you all inviting me from US, and you have created a really good program on COVID-19 international speakers. I'm an internist and I have a unique position. I do inpatient as well as outpatient practice. So I have over 3,500 diabetic patients, and most of them are on ACE inhibitor or ARB for their blood pressure or for renal protective effect of the ACE inhibitors. So when we talk about the role of ACE inhibitor and ARB in patients with COVID, we need to look at the physiology and renin, angiotensin, aldosterone axis. As you all know, renin is produced from the kidney, and it converts angiotensinogen to angiotensin 1 in the endothelium of the lung capillaries, and angiotensin 2 is produced from angiotensin 1, and that is vasoconstrictor. Now, also we know that COVID-19 enters into body through ACE receptors, which is a protein enzyme which is present in the lining of the alveoli and pneumocystis 2 cells. And if we see that ACE inhibitor will reduce the production of angiotensin 2 because it's a blocker, it blocks from angiotensin 1 to angiotensin 2. Now, ACE2 receptors are dependent, or their expression is dependent on the concentration of angiotensin 2. So with angiotensin 1 receptor blocker or ACE inhibitors, we have positive role in COVID patients because it is going to reduce angiotensin 2 receptor, angiotensin 2 concentration. In return, it will reduce the number of ACE receptor, ACE2 receptors. So in my practice, what we have done, that patients who were on ARBs, we have converted them to ACE inhibitors with good result, with severity of the disease. As I mentioned, I do outpatient and inpatient. So I've seen positive result, people who were not taking ARBs as compared to people who are taking ARBs. Thank you.
Thank you very much, Fateh Shehzad. Now I would like to bring Dr. Majid Mushtaq, who is co-chairing with me, and he will ask questions to the panel.
Thank you.
If there's
Thank you.
time at the end, I'll come back.
Thank you, Hafeez. And may I congratulate the management and appreciate the speakers for excellent program and talks. So I'm just going to quickly finish where Hafeez has started already. The question to Dr. Gaba, the Waqar Gaba, the stroke which you mentioned, and there were a number of people who had stroke, were there any theoretical or actual linkage with stopping the anticoagulation on these people, and would continuing the anticoagulation had helped, or has anybody thought of that?
Okay, thank you. So stroke is very close to my heart. We all know that with the stroke, when you have a large vessel artery stroke, in these COVID patients, we saw that the COVID was affecting the large vessels, and mostly the patients were presenting with the stroke, and COVID, they had large vessel involvement. Now, with the large vessel artery strokes, you always have a risk of hemorrhagic transformation. And as we well know, in these patients, we don't anticoagulate them upfront. So we give them either high dose of aspirin and loading dose, and then put them on like a low dose aspirin, or carry on with antiplatelets until we find out whether they have any underlying atrial fibrillation. And then of course, we start them on anticoagulation depending on how big the stroke is. That could be leading from, you can follow 1-3-7-12 rule, depending on how big the stroke is. In these patients, if we ignore the COVID, you should not be starting anticoagulation. Now, going back on your question about anticoagulated patients. So as I showed you our cohort of patients who presented with pica strokes, we saw that some of them, actually 4 of them, were already on either DOAC, either on warfarin, or either were given high dose of anticoagulation. and despite that, they did have a stroke. So I think probably it's very difficult to say that whether anticoagulation or full dose anticoagulation would have prevented or will prevent further progression of the stroke, with the accepting the risk of the bleed. Though if I say we should stop it, I think probably no, we should carry on with anticoagulation if they were already on, because that might prevent the progression.
Thank you. Thank you very much. My other observation, and somebody has already asked that question, we got range of other organ involvement, pancreatitis, encephalitis, myositis. Do we know the outcome of these, and would these be extraordinary to the normal post-viral associated inflammation in the body, as we have all experienced pre-corona time related to other viral conditions?
So I think, is this a question for me?
Yeah, Dr. Waqar.
Okay.
Yeah.
Okay. So I think, again, these are small cases or case series at the max. Sure. Okay. So we can't just rely on these to say for definite, and we're still seeing the effects of the COVID. Now, yes, you're right that we have seen all of these with association of different viruses. Okay. So there is assumption is that, of course, COVID, if other viruses can do the same, then COVID can do the same as well. But not to that extent. We have been seeing in such a short period of time, we have seen so many varied presentations of COVID. We didn't see it with SARS, we didn't see it with any other viruses, but we are seeing with this virus.
Great, thank you. Could I turn to Professor Greening now? Excellent presentation, and thank you for putting the recovery trial on the map again. Could I ask you, and this actually question was asked by Dr. Talha Munir, who is also present, whether did you, in the recovery trial, the dexamethasone effect, was there any subgroup analysis of the BAM population or people with diabetes, and whether there were any differences?
Thank you very much. I think that's a really interesting question, isn't it? The answer is none of it's been reported yet. We really have the headline figures. I saw that before, and I've been through the supplement, and ethnicity is not even reported at baseline characteristics in the recovery trial. I think it will be a question. I think with the large number of patients recruited in Birmingham, Leicester and London, in particular, we should have good diversity. I know in Leicester, we have a huge diversity here, particularly in post-COVID follow-up, but it's not known yet.
Okay, thanks. And we got international audiences, and lots of people have asked about various drugs. I probably know what your answer is going to be, but could I ask you directly? People have asked about vitamin C, lignocaine, interferon, etc. What would you say to those audiences?
I mean, there's a mix on different things. So people are quite interested in the beta interferon, because there's a mechanistic rationale for it. Beta interferon has been trials, unfortunately failed in aspirin COPD in the past, and there has been a very positive phase 2 study using nebulized beta interferon, but it's small numbers, and I think I wait and see. But they've reported a very large decrease in progression to requiring ventilation in the beta-2 interferon trial. So I want to see that recreated on a larger, proper scale. I think the anticoagulation question is still to be had. We know that all our patients are on prophylactic dolteparin or low molecular weight heparin. There is a trial, or there are multiple international trials ongoing of full anticoagulation in high-risk patients versus not, and I wait to see what the heparin results are for that. Vitamin C, lignocaine, less data so far.
Thank you. Thank you very much for making it clear. Should I move to...
May I come in to ask one question to Professor Neil Greening?
Yeah, go ahead.
Neil, excellent talk. Thank you very much for your time on Sunday afternoon. So my question is about tocilizumab and the attitudes of different countries of using it. You know, in England, we strictly follow evidence-based medicine, and we are not giving this medicine to anyone outside clinical trials. But when you speak to the colleagues across the world, especially in Pakistan, India, and USA, I mean, tocilizumab is being giving like I say like peanuts really, and outside clinical trials. And if you speak to those people from their observation and from anecdotal evidence, you really sometimes like to believe them that yes, you're based on observation, I should be giving the tocilizumab. And I will bring it back to another question of that. You know, many people are saying that yes, UK has come up with the recovery trial. Dexamethasone is a life-saving medicine, but they have been using this steroids even before recovery trials were out. So that kind of thinking, I mean, can there be any global collaboration that these types of experimental medicine should not be given to any patient outside clinical trials? Otherwise, we will not know which medicine works, which one does not work.
I think that will be the long-term outcome from this. I think the states have woken up really well to it now. There's a lovely commentary in one of the journals from the states saying, why were we not there doing that? So I think the United States particularly will wake up and start thinking about long-term collaborative research, and I think that's got to be it, because we've got to think about putting in ISARIC, of course, which is the observational cohort study, is an international trial, but we have to have joined up services that are able to deliver it, and that's where some number of countries can fall down on. So I think, yeah, I worry about it, but I think the US in particular has woken up to this.
I think I will fully support Dr. Greening. I think the press and the WhatsApp is flooded with, you know, sometimes contradictory, sometimes something which you want to believe in stories. But the answer is that in this hour of great suffering of humanity, we should not lose our eyes off a well-researched drug. So can I move to Dr. Asim Siddique, and may I congratulate him? It was a fantastic talk. I felt that you were a bit rushed for time. So I'm going to ask you 2 or 3 questions which you probably didn't have enough time to explain. You mentioned helmet ventilation versus mask ventilation, and your department tend to support helmet over mask. Could you just briefly elaborate on that, please?
Yeah, so with the BiPAP, CPAP, or any other mask, the risk of aerosolization is just very high. I just had a slide which I had to delete, but the risk is about 5 to 6 times higher with, with the CPAP or BiPAP, because there's an exhalation port. There are some studies from China and US where they have swabbed different area. Oh.
We can hear you fine.
Okay. They've swabbed different area of the room. If someone was on, let's say, Venturi mask, and almost every surface in the room has COVID on it. So that's why in US, most of the societies say that you should not use masks, especially CPAP, BiPAP. There's a mask called Jason mask, which covers, most of your face, including the eyes. That can be used, and we've used it. But with helmet, because it's very contained, it works better. The second thing is that a lot of time people are just claustrophobic when they have, a CPAP mask if they're not used to for sleep apnea. So I think the difference is aerosolization, the difference is comfort, and the last difference is just the less risk of aerosolization. So
that's fantastic. We would like to, if you could share that data with us, because we are primarily in Britain a mask-related NHS, and this will go a long way in lobbying our BTS to see whether that practice need to be changed.
I think Professor Greening has raised his hand. He will like to ask a question.
Dr. Greening?
I think this is a really interesting debate, because I agree with you. We had this debate in hospital. Our worry about the hoods was not necessarily during the use, but the taking off of them. The worry is that they become a huge reservoir, because you can deal with masks and you have an exhalation port that you vent out. You can have viral filters on them. our worries taking off the CPAP hood and a sudden large dose going to patients. So I wondered how you got around that.
What we have is, again, I just did not have time to show that, all this innovation, but we normally use PAPers for that, or nappers, meaning that, you know, the person who's going in has a whole hazmat suit, and the PAPer, and then every time they take the hood off, it's cleaned before it's put in next time. And then there's something called a HEPA filter. It's like a commercial grade HEPA filter, you know, which is approved by CDC and all that. And then there's a way to increase the filtration on it to 4 or 5 times. So what we do is increase the filtration, put the hazmat suit on, put the PAPer on, go and remove the helmet, clean the helmet, and then do the same thing when you have to put it on. And we use the same thing for intubation and extubation, and if someone is on CPAP. And that's why if you look at the healthcare workers' infection rate in our hospital, they're very low, except that when there was some community spread. I mean, going at 1% when you have more than a few thousand employees is just remarkable when you're seeing this many patients. And that's what we're doing right now.
Yeah, so the trick is that when you are likely to be exposed post helmet, you have to put on proper protection, which sometime in NHS we don't practice or is available.
Thank you very much for all the presenters and audience who have patiently sort of listened to us. And I hope, I mean, their queries must have been answered. There are lots of questions which you can still post on chat, and we will try to scroll through them, and hopefully we can ask the panelists to answer them if required. Thank you very much.